Good afternoon, and welcome to HealthSystemCIO.com's All-Star Panel, Unifying Communications to Improve Healthcare Workflow, a webinar tweet chat combo from HealthSystemCIO.com, sponsored by Spok. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I'll be your moderator today. We do have a simultaneous integrated tweet chat going on, hosted by our Managing Editor and Director of Social Media, Kate Gamble. You can participate in that by opening a browser and tweeting using the hashtag HSCIOchat. If you would just like to view the tweet chat, you can open the Media Viewer panel in your WebEx console. About your WebEx consoles, you have Media Viewer, you also have a polling and a Q&A panel, and we'll be conducting some live polling later in the program. If you want to reopen your Media Viewer and review the tweet chat, just click on the little arrow next to it, and you can use that to navigate your panels. You can ask a question at any time by using the Q&A panel in the lower right-hand corner of your screen. You leave the default set to all panelists and go ahead and send in those questions as they occur to you. We'll get them in front of our panelists later on in the program. You can download the deck using the URL on your screen, and we've got a shortened URL at the bottom of all slides. And we are recording the event, so we'll have an archive ready within 2 business days, if not sooner, and you'll receive an email as soon as it is available. Just so you see how we're going to spend our time today, we're going to have our panel discussion of about 35 minutes, and then we're going to have our audience Q&A, and all will go about 45 to 50 minutes. And our panel consists of Paul Conoscenti, SVP and CIO at City of Hope Medical Center and Beckman Research Institute, Lisa Stump, Interim SVP and CIO at Yale New Haven Health and Yale School of Medicine, and Brian Eds, VP of Product Strategy with Spok. So without further delay, we're going to get right into our conversation. Paul, let's start with you. Can you give us a little overview of your organization?
Sure. City of Hope is a nationally recognized leading research and treatment center for cancer, diabetes, and other life-threatening diseases. It includes a 200-plus bed acute care hospital. We have 15 ambulatory centers across Los Angeles and Riverside counties. There are over 250 physicians with multiple specialties, internal medicine, et cetera. There are 3 research institutes. We have a Beckman Research Institute for Diabetes and Research Institute, and a Hematologic and Stem Cell Transplant Institute. We have a Graduate School of Biological Science, and we do a fair amount of philanthropy and have 8 regional fundraising offices across the nation. So City of Hope is a very nationally recognized cancer and research hospital. Great.
Brian, you want to tell us a little bit about Spok?
Sure. So I'm Brian Ed, Vice President of Product Strategy at Spok. Spok is a provider of critical communications around the world. And so we've been in business for over 2 decades. We have 600 employees located around the world, and we are a publicly traded company. And so we provide a variety of solutions that really help power enterprise communication, specifically in healthcare.
Excellent. Lisa.
Sure. So Yale New Haven Health System is a regional health system in the state of Connecticut. We are comprised of 3 inpatient hospitals, Bridgeport Hospital, Greenwich Hospital, and Yale New Haven Hospital, which also comprises our Smilo Cancer Hospital, the Yale New Haven Children's Hospital, and the Yale Psychiatric Hospital. We total 2,200 inpatient beds, and that generates about 109,000 discharges every year and about 2.2 million outpatient visits across all of our ambulatory settings. We are supported by just about 6,500 physicians and over 20,000 employees across our health system. And in that environment, I think you can see that communication is a critical function for us. So I'm looking forward to our discussion today.
Very good. Let's jump into a little bit of a discussion about interoperability, sort of laying the framework for some of what we're going to talk about today. Paul, how would you describe the state of interoperability, and how do you think it's going to evolve in the next few years?
Well, the current state, I think, quite frankly, is sort of ad hoc, immature, and at a very early stage of use. We have meaningful use, which is out there with HIEs requiring us to have like 50% of our transitions of care using CCDA records and transmitting using a direct ID, and perhaps some organizations are using this, but I found that most have this vendor proxy set up and, sort of early stages. Even secure health messaging, meaningful use requires like one patient to send and receive to get a message to get meet the requirement, which is hardly a critical mass, and the various HIEs and other types of communications are really at this point, I think, point-to-point more than really a collaborative interoperability. I think this really provides a challenge for care providers because there's not enough critical mass to give them an incentive to change how they adopt or interoperate and include that in their workflows. I think there's some early stages of use. We've got standards, but it's going to take a little while to get going. I think in the next few years, we talked earlier about growing up sort of like an adolescent. We all think we know everything, but we have a lot of learning to do ahead of us. We have payment reform, population health, consumers really will drive the interoperability. And right now we have point-to-point exchanges between, Epic to Epic and Cerner to Cerner and this to that, but really having a public or a private network where we can really share the whole continuum of care is some way off in the future. I think some of the incentives and operationally, as well as some of the technical challenges with bringing some of these systems together, will evolve over time. But I would say we're at an early stage of maturity.
Lisa, where do you think we are? Agree with Paul?
Yeah, I agree with Paul. I would say today our ability to interoperate effectively is largely driven or not by vendor-specific constraints or standards. And I'd probably take that one step further and say that it's further constrained by us as clinicians ourselves. So we don't have a common language across clinicians, and where I might call a central line, and you call it a central venous access device. Technically translating that to cross through an interface and land in the right place in a different EMR is incredibly challenging and really puts a lot of burden on both our clinical analysts as well as the integration itself between the two systems. I think we're starting to see some development, through the use of more open APIs. So we are successfully here even getting Epic to communicate well with AthenaNet as an example. And I think the use of open APIs is going to continue to allow us to expand that as we go forward. And the public drive, the patients accessing and sharing their own data, I think is probably going to be one of the main sort of drivers around the industry and us in health systems needing to support and advance that. Patient control over their data, I think, is going to be a key thing for us all to watch and to contribute, their ability to contribute, share, and access their own data.
Brian, anything you want to add to that?
Yeah, I would agree with kind of both of their statements. The term that I often use to describe kind of where we've been and where, often the pace we were interfacing, we had the ability to, do really simple transactions back and forth, and that's really kind of where people lived. But I think in the future, really kind of the word is maybe integrated instead of interfaced, and really trying to move to a world where there's much more common sharing of information, not just, point transactions.
Excellent. Okay. Before we move to our next question, we're going to get a related poll question out there, and you're going to see it in a moment. And the question is, does your organization currently have a unified communication strategy in place? And you have a number of options to pick from. So right now, you should see that poll in your polling panel. Go ahead and answer the question, and we'll be able to discuss the results. So Brian, let's stick with you on this. Do you see the industry, you see a big shift going on? I mean, on our end, we certainly see a lot of interest in the space of unified communications.
Yeah, there's definitely a lot of things changing, and I think what's changing is largely a reflection of the changing ecosystem of healthcare, but also this drive from kind of a fee-for-service world to more kind of value-based care. And what that means is that, you know, in the past, each department made their own selection around communications technology. Maybe nursing chose their own set of communication technologies, physicians, maybe each physician group chose their own set of technologies. Biomedical engineering had their own set of solutions, and the telecom and IT organizations really worked to try to plug these together, to interface them together. And so, you know, what we're seeing is because there's an increased need for collaboration in healthcare, because the workflows are not just going from the ED to radiology and back again. Maybe they're going from kind of a local community hospital to, you know, an acute care tier 1 trauma center and back. You know, that's starting to change the way the expectations around this. And so when we talk about care team communication, having different solutions for each department really makes, you know, communicating with that care team rather difficult. And so the shift we're seeing is really a focus on enterprise solutions that can really cross these departmental or even physical location boundaries.
Excellent. We're going to have those poll results in a few seconds, but Lisa, give me your thoughts on the shift going on, if you see it.
Yeah, I absolutely agree with Brian. The need to collaborate across a much larger, what we consider care team, and across very diverse geography and types of care settings is going to continue to shape healthcare and the need for unified communications as we go forward. You know, having come out of the clinical world myself, I would tell you, and now interacting and trying to solve those problems for our organization, there is no magic answer to the right number of solutions and the right number of devices. Minimizing the variety where we can, I think, is key, and then having it all seamlessly and easily interact, however many systems are needed on the back end, needs to be transparent to our front end users. And so we can't have a physician needing to access 3 different solutions depending on who they need to communicate with or who needs to communicate with them. And, you know, underlying all of that, and I know we'll talk about lessons learned, but there are some definite lessons around the infrastructure, both technical and the data architecture that we need to support all of that, because there's very little tolerance for our clinicians and our patients. It needs to be easy, seamless, and transparent as we go forward.
Very good. Well, now I'm going to share the poll results with our audience. Paul, we've got 27% fully implemented a unified strategy, 40% have partially done so, 20% they don't have a strategy in place, but they're in the planning process and not at the forefront of our priorities, 13%. So the plurality, 40% have partially implemented. Does that sound about right to you?
Yeah, I think it does. I mean, it obviously the polls are the polls. I'm 40% fully implemented.
Partially.
Actually sounds high. Partially.
40% partially. Yeah.
Yeah. Yeah. Yeah. And you know, it goes into you know, how do you define partially? Okay, because what I think we have is which in my terms would be everyone has some piece, okay, but is having one piece truly unified, okay? And so, you know, so we use technologies for secure text and things like that. But you know, how does one define a truly unified communication strategy? And if it's partially implemented, I would ask, is it partially implemented because you have a strategy, a full unified strategy, and you've only implemented a piece of it so far? Or is it that we have a piece here and a piece there? So I think depending on how you view that question, you know, it may or may not make sense. So I would say 40% sounds about right, but I would also wonder, is it really, do we have a full, you know, a unified strategy and we're implementing pieces of it, or we have a piece of a strategy?
Right, right. Brian, can you help us with this? Taking a look at the question, and do you see the results? What are your thoughts? What do you make of the results?
Yeah, I think the numbers sound about right, but I question, just like Paul does, the you know, the definition of unified, right? And so you know, everybody in a healthcare setting today has some sort of communication device, and as we kind of try to unify them, you know, bring them together, would I say that 40% of hospitals, or even 13% of hospitals, have the ability for anybody to get a hold of anybody seamlessly? And I would say the answer is far below that. I'd say that's no. And I think it kind of goes back to, you know, really defining what unification means, and, you know, mapping out those workflows and really having a strategy around this, because I think there's been a whole bunch of activity. I think there's been a whole bunch of implementation of various communication technologies over the past decade, but I think really formulating a strategy, which means clearly articulating who all the roles are, and what workflows they're involved in, and what information they need access to, and how they're going to get a hold of each other. I don't think that is often done. You know, we're at Spok often involved in a lot of those types of discussions, and I can tell you there's lots of interest in planning that. So I was trying to figure out what I was going to predict, and I would have predicted that C would be the most common answer to this, rather than B.
Interesting. Very good. Lisa, let's start with you on this next question. What are some of your biggest lessons learned as you've tried to move down this road?
Yeah, I think one of the earliest lessons we learned, you know, there's the old adage, garbage in, garbage out, and we often look to technology, and whether it's a texting platform or some other communication vehicle, and its ability to move a message from point A to point B is often very sound, and that all works. But at the core, if we don't have the right contact information, right, or understand how people prefer to be communicated with, that data set at the base of a unified communication strategy is critical. And we started down a path, you know, to the point of, are you partially implemented or full? I kind of think we'll always be partial, because I think the landscape around us is changing. But, you know, we learned early, having started down a path, that we had to step backwards and relook at all the sources of data on who we communicate with, what telephone number, what fax number, when to use each of those, when do we use email, when do we use text, and being sure our data was complete, comprehensive, accurate, that we have a mechanism to update it on a regular and frequent basis. And, you know, talking with colleagues across the country around this, we're all sort of struggling with that same issue. And it relies on, again, not just the technology solution, but good policies and procedures internally. You know, what is our expectation for employees and physicians to share their contact information? Will we require personal cell phone numbers to be part of the communication, library or directory? And we're still, I would say, finding our way through that. Do we have a plan? Absolutely. Do we have the technology pieces in place? We do. We're working through those data mapping pieces, and then, I would tell you the people part of that equation around the keeping the information current, sharing all the right information, I think for healthcare organizations will continue to be a challenge. And if someone's done that incredibly well, I would love to hear from them.
Yeah.
Paul?
I agree with Lisa. I think there's a lot of thought process that has to go into it first. I mean, the bottom line is we need to understand what our current problem state is, both from a technical point of view and an operational point of view, to really generate a cohesive strategy and pull the pieces together. I find that the strategy really and plan needs to go between 12 and 24 months out, and you need to really think that way. It's not something that's going to happen overnight. You have to pick a partner and a use case that really plays well within the organization, but also across vendors, and those vendors are ready to integrate. And really, the other main lesson learned is you can't force the issue. You have to sort of go slow. You have to integrate. You have to integrate into the EHR. Okay, these solutions that try to work around the EHR because it's too difficult, in my opinion, haven't ever worked. It always will get stalled by the fact that it's not truly integrated. It doesn't necessarily mean you have to use that vendor's product, but it must be integrated in order for it to work. And then you have to go in small chunks and measure results. It does matter the simple things. I mean, for example, we were trying to put in our physicians, when they call out on their phones, the main number shows, and they were having issues because the person didn't know where to call back to. Okay, and then we went through this exercise like, okay, so where do you want it to call back to? Well, do you really want it to call back to your physician's number? Well, not all the time, sometimes maybe. And so we went through what seems to be a very simple process. Okay, what's the caller ID on my phone when I call out of the institution? And it gets into, so, well, in some cases it should be the call center. In some cases it should be the, surgery call center versus the other one. In some cases it may go into the department where their executive admin will pick up. And in some cases they want it to be the doctor. So all of a sudden these relatively simple questions about how do you communicate in what instances becomes a major stumbling block, and unless you actually get down to that level and understand where the problem is, you kind of miss a lot of opportunities to really bring it together. So I would just say that you need to start slow, make sure you're integrated, and do it in small, digestible chunks and measure the results.
Paul, let me jump in with you with an audience question. So what happens when not all EMRs are integrated, and what's the definition again of integrated?
So, for example, if you're sending out a text message, okay, and it's from your call center, and it goes to a physician, and the physician gets that message about a patient, they should be able to then, on their device, get access to the patient's record about that question that the call center just called about. Mm-hmm. So you're not going to be able to bring up the patient's record unless somewhere along the line in that unified communication channel there's some secure link that has the context of the patient and who that doctor is, so they can click on it, bring up the record, and then answer the call. So without that, then the physician is going to be sort of juggling different things. Oh, I got to go on to, I get this text message, but now I got to hop on to some other application, even if it is a mobile app. It's disruptive. They have to look up the patient's name and so on, and then they have to call the patient back. So all of that workflow, okay, 90% of the questions are going to revolve around some piece of information in the EHR. So I think it's really important to do that. For example, even secure messages that come out of the EHR, our physicians want to at least know that they got a message on their email, okay, because they're not in the secure messaging at the desktop all the time, or even in that application. They want to be able to get it multiple different ways. So in order to be able to make it useful and have a unified communication strategy, those touch points need to be carefully thought through so that there is the appropriate access where needed when you do need to have information from the EHR. That's what I was trying to get to. Does that make sense?
Yep, I think so. All right, let's move on to our next question. Brian, I'd like to get this one in front of you. You speak to a lot of different hospitals in your work. What do you see as common pain points and themes that some of our audience may be feeling right now in this area?
I think the best way to summarize it is they're trying to solve problems that improve the patient satisfaction, right? And so Paul gave a great example of really simple things like caller ID that can get in the way of patient satisfaction. They simply want to be able to call somebody back and call the last number on their phone and be able to solve that. And so, you know, at the end of the day, that's the goal, right? And so there's, on the other side, from a provider standpoint, there is the concerns around alarm fatigue or message fatigue, right? And so your electronic medical record, your inbox, whether it's your Epic inbox or other inbox, is often overloaded. And so there's a lot of communication going on, but there's not a lot of you know, data being transferred because there's just such simply an overload of communication from providers, from systems, things like that. And then finally, you know, we've been talking about this important interoperability with the EMR, and I would say that there's been a whole bunch of integration with EMR on the back end. There's data sharing, but they're really, you know, to Paul's example around really being able to, at the glass, from the end user standpoint, provide interoperability so people can move seamlessly from a communication solution to an EMR to a portable image viewer to all the various types of solutions that we're going to have on our device. I think, you know, the pain points, we're trying to make it really simple for both the patient to communicate with their providers and for the providers to get back with their patients. That's the end goal. And so, you know, those pain points end up coming down to being able to get a hold of that right person, however I get a hold of that information. And whether that information is in the EMR or another system, we need to take that data and really make it available to that provider and or that patient so it's seamless.
Very good. Lisa, let's go with you on this one. Can you speak to any results from improved care workflows that you've seen with regard to either patients or clinicians?
Yeah, you know, we have several examples, and I think they touch on the pain points that Brian just spoke about. So, you know, improving our patient satisfaction and engagement is a key priority for the health system. And one of the things that we heard loudly and clearly from our patients was that when their friends or family accompanied them to the hospital or to an ambulatory setting for a procedure, you know, the patient goes off and we take good care of them. They go off to the procedure area and their guest is sitting in our waiting room, sometimes with those little buzzers that go off like you see in the restaurants. But for the most part, it's a black hole once the patient goes off into the procedure area. And so part of our communication strategy was to create a secure texting mechanism where our staff could communicate with whoever the patient said we could around their status during their treatment. And that's been an incredibly successful process for us. So again, to echo what Paul said, we started small. We did a pilot in one of our ambulatory surgery centers to make sure that the technology was sound, that we could communicate well to family members on what they actually wanted to hear, and to garner their feedback. So we did measure the success of that, and it's been incredibly positive. Both the patient satisfaction scores as well as the feedback we get from the family members very much reinforces that having a good way to communicate on status is really important. The workflow for our staff, we were able to monitor and make sure was efficient for them. Appropriate integration, again, some of the pain points, so having integration to ADT messages as patients move through our system all made that one a very successful process. One of our other goals, where we've had some success is really improving the efficiency around communication. So we operate, several large inner-city emergency departments across our health system, and what we often heard from the nursing staff and other clinical staff in the ED was that finding the physician in our big, busy emergency departments was often difficult. Needing to step away from the patient to look up a phone number in the computer system and then get to the phone and call them was all taking time away from their patient care and time at the bedside. And so, again, part of our communication strategy is an application that runs on a mobile device that allows our care teams to communicate with each other very seamlessly. And our nurses, I think one nurse said it very well, it's now like having the doctor in her pocket. She can pull out that mobile device, immediately contact the doctor. She doesn't need to know their phone number. She presses the icon that's for them, and the message goes right through. Again, either telephonically or via text, depending on what's appropriate for the circumstance. And so hearing that, again, was very positive. And we were able to then extend that same platform to support. We operate a tele-ICU here in the health system, and so from a single centralized bunker, we have critical care intensivists that are now able to monitor patients across ICUs across our entire health system, and again, leveraging that communication platform to allow the staff in the bunker to communicate seamlessly with the staff at the bedside has really allowed us to improve the outcomes through our tele-ICU, and all of that, again, integrated through the EMR. So Paul and Brian, I think, described really well the how and the pain points that we're trying to solve, and I think we've seen successes in each of those areas.
Excellent. Paul, you want to talk a little bit about any results you've seen from improved workflows?
Sure. I think that see exactly what Lisa and Brian were experiencing. We've seen the same results. Care coordination in a cancer center, it's all about the care team. And there are some great physicians, but the care team really, really matters because the patients are coming and here for the day, and especially in an ambulatory side. So having a care team coordination system that, begins at the call centers, touches the nurses, the MDs, and all the other clinicians, supportive services, et cetera, it makes all the difference in the world and brings the teams together. That has to go hand in hand with what we were talking about earlier, because how do you get those messages in the hands of the providers that you need to get to? And so really we've begun to really see some improved in our patient satisfaction scores, and also we haven't really measured better outcomes as of yet, but we kind of feel that that's what's going to happen, because the teams are much more coordinated in their care. We're next going to be actually integrating the care coordination system as a tab in the EHR, because a lot of this communication is not necessarily part of the official record, but it's very important to the overall care. And so as we define and refine our care coordination strategy and communication strategy, we see that having that accessible to the care providers at all times really does improve care. It also helps our operations to be more efficient. So we don't have any hard data at the moment, but we do have soft data showing that these are areas where we will find improved workflows. Now, improved care workflows go with changes of workflows, okay? So the flip side of that is you in order to have this improved care, you've got to change the workflows that you're currently using, and that becomes something that has to be really thought through, because the old ways of communicating sometimes get in the way of what we're trying to do here. Right.
Change is the hardest part.
Change is change.
Yeah, nobody likes it. Nobody likes it. We're going to do another poll now, which will be related to our next topic point. The poll, when I send it out, is going to be a multiple select, so you can select more than one answer. Which groups have you involved in unified communications? The choices being physicians, nurses, administrators, ancillary staff, and patients. So you're going to see that poll open right now, and again, you can select more than one answer about which groups you've involved in your unified communications work. So please go ahead and answer that poll now. Lisa, let's start with you on this. Unified communications encompasses a variety of departments and roles, as our poll indicates. As CIO, how do you spur adoption of new technologies or encourage culture shifts from diverse groups?
Yeah, it's a great question. I think the key always in good adoption is first ensuring that we're actually solving a real pain point, right? We shouldn't be deploying technology for technology's sake. And when there is a real clinical or operational need, the engagement and involvement of all of the right stakeholders, and the list that you have in the poll that's currently going on, I think, encompasses that spectrum really well. Then we have to ensure that the solution works, not just technically, but in the workflow. So it is always critical to make sure that what we're implementing fits in the workflow, the new workflow that we're designing. And again, in these clinical scenarios, it often does need to revolve and through the EMR. So that's been key. And ensuring it works technically, I think really important for us on the IT side. Even minor hiccups early when we roll out a solution shake people's confidence, and I think we do try to avoid some of that through really good, solid testing of both the technology itself and the workflow that we're trying to implement. And then we need to monitor performance and outcomes. It's really key to demonstrate with data that we've solved the problem we intended to solve. And we know we're successful when, after that first small pilot, I'm getting the daily emails about when someone can be next. To have that technology is then really clear that we're truly solving a real pain point. So I think that's key.
Very good. Reminder to our audience, go ahead and fill out the poll. It is anonymous. We're going to close that poll in about 20, 30 seconds. Again, it's an anonymous poll, so go ahead and fill it in. Paul, your thoughts around how to get people to change?
Well, yeah. Let me take the high road on that one. So I agree 100% with Lisa on this. It's got to be very carefully thought out. For us, it was the champions were nurses. And then we had to get involved with the schedulers, the physicians, case managers, support services, other key departments that are involved in the communication, and define some sort of a standard of work associated with that. I believe that the key message, I think, and Lisa pointed to this, is that it is not a toy. Okay, you need to make sure you have this set up properly, configured properly, technically hitting the problems, and actually have a workflow that matters. Once you do that, then you need to provide support and training and a little bit of marketing perhaps, but really support and training, and the adoption specialists need to really get out there and avoid people getting frustrated with this new technology. Even if technically the technology works, they're going to get frustrated with just how to use it, and how to use it effectively. So the training and communication of the communication strategy itself is really, really very important. And because there will be a lot of disbelievers out there until you get a critical mass of folks that actually say, oh, this really does help, because there's such a propensity to still use email, okay, and the old techniques where email is good and it's part of the communication message, but in order to have a care coordination system that deals with teams, you really need to deal with the change of workflows, but the technology has to be right, and it has to be viewed as a mission-critical application, not something that we're just going to play around with. So again, that's what we found, and then the departments sign up, and now it's sort of like a mantra. They believe in it. And every time you go to a meeting, it's like, okay, well, we could do that in our, in our care coordination system, and blah blah blah, and so it's wonderful to see, but it took a year or two to get to that point. Right.
All right, let's go ahead and share our poll results. You can see them on your screen. Brian, let's talk about the results. Obviously, the things that catch your eye are nobody's involving patients, and only a few involving ancillary staff. Anything on there surprise you?
It's encouraging that a lot of people selected, including all of those other groups. I'm a little bit surprised that patients aren't on there, because we're starting to see that as an important part of kind of that care team. But no massive surprises.
Can you talk a little bit about involving patients? And because if people aren't thinking of that, I guess you're recommending that they should, and how should they?
Yeah, so as patients, their patients and their families are increasingly a part of, the care team, and they're involved in decision making, and they're involved in understanding what's going on. And obviously, a lot of communication, has been deployed using patient portals over the last several years. And I think that has, served its purpose. But I think people are starting to think beyond that and think about how can the patient. I don't think there's a lot of great solutions for patient communication out there. I think this is kind of an unexplored territory for a lot of folks. But they should definitely be understanding, when they're developing their unified strategy, what are those requirements? When should the patient be involved? When shouldn't the patient be involved?
Yeah, I think I just want to jump in just to help explain what I think might be the case here is I think we all agree that we want to include patients at some point, but if we don't have our own house in order, when patients call, it will be a mess. So I think what you're seeing here is perhaps a baby step towards let's make sure we could communicate amongst ourselves before we open up the external world to this whole process. So that's just a thought that perhaps is reflected in here.
Very good. All right, let's go to our audience Q&A now. We have a few minutes left, so if you have any questions, send them into the Q&A box to leave the default set to all panelists. Lisa, let's start with you with the first question. In regards to interoperability, it seems like a vendor-neutral archive would solve some of the issues. What's your point of view on that?
I think the concept of a vendor-neutral archive is promising, and I think we are starting to see some of that come to fruition in the areas of, sharing images as an example. I think we probably are still at least a few years away from a truly vendor-neutral archive on all of the clinical data that we accumulate through electronic medical records and the care that we provide. You know, I think the HIE vendors, if you will, have tried to fill that gap. What's critical to all of it, again, I'll go back to the importance of the clinical workflow. Collecting and aggregating the data is one step, but it then has to be presented to the clinician in their, frontline workflow as they're making the decisions and as they're, performing their own review of the record and their documentation. So I think there are lots of pieces that we need to put into place, and even a vendor-neutral archive would only be one piece.
Paul?
Yeah, I think that that it will evolve. I think technically there are it's a little bit disjointed at the moment to have it as a vendor-neutral archive. Perhaps it would be more viable as a cloud-neutral archive of sorts, because I think the cloud might give us some of those capabilities to truly be unified from a communications point of view. And I do think that it will be up to the patients who are going to drive that type of technology transformation, because it's like physician to physician, institution to institution. We're sharing images and all that sort of thing. But across all the various care settings and engaging the patient is not where we're at. So I think when the patients begin to demand it, we'll be more, we'll have more incentive to create a vendor-neutral archive. I do think that it would be some cloud-based solution that perhaps would be provided, perhaps through an HIE of sorts, whether be it public or private. But it's technically there's no true there's technical solutions to it, but there's no incentive to do it at the moment, at least as I see it.
Very good. Well, that's about all we had time for today. When you close out your WebEx viewer, you'll see a survey pop up, a post-event survey. It'll take you about 30 seconds to complete, and we'd appreciate it if you would. I want to thank our panel, Lisa Stump, Paul Conoscenti, and Brian Eds. And I want to thank Spok for sponsoring the event today. You'll receive an email, as I mentioned, when our archive recording has been posted to our YouTube channel. For those of you who hold the CHIME CHCIO certification, attending our webinars gets you one CEU. Make sure you let CHIME know you were here, and if you've asked us to do so, we will. Sponsorship opportunities, you can contact Nancy Wilcox. If you need a certificate of attendance to show you were here, you can use the final slide in this deck, and you can go to our website to view our upcoming schedule of webinars. So once again, I want to thank our panel. I want to thank our attendees, our sponsor. Everybody have a wonderful day.
Thanks, Anthony. Appreciate it.
Thanks, Paul.